what we wanted to do was, Elanco and myself, just try and summarize this, or actually give it from our point of view of what might be happening in 10 years. So it's personal. It's not what I'm predicting. I'm just trying to look at it. And so I'm going to, there's not going to be one model. I'm going to stick to a London type or a big conurbations. And Elanco is going to talk, because he's coming from Poole, what might happen in district generally type areas where the anatomy of the land might change what you can provide. So I jotted a few things down. The first one was, I've heard on a number of occasions people getting all upset about people having consultant status, this, that, and the other, and they haven't done this, and haven't done that. I want to put that to bed right now, because actually, basically, status is not about a name. Status is what you do. And you can have people who are fantastic, and their status is high, and they haven't gone through long training pathways, etc. So I want to kick into bed this concept of status. I think we shouldn't be arguing about it, and I want to exclude that. I think that when you look forward, you can tell the future. It's vague, it's fluffy, but you look for some riders that are going to dictate. One of them is that the government has stated, and in one of the documents Clark's given us, it wants a consultant-delivered service, not a consultant overseen service. Okay, and so you have to ask that in the way forward. Who's going to deliver this? Are we going to deliver it with sub-consultant grade? Because that's not what the people want. And I also like the concept of seeing money as energy. Dentistry is a £2.8 billion industry. MaxVac is 500 million. Which is the most potent, ultimately? Okay? Look at it in terms of energy forces, in terms of where things are going. And the whole of that 2.8 billion being delivered by sub-consultants is going to be silly. It's not going to happen. So we've got that as one rider. We've got data collection that's going to come in, and we're going to be paired off against each other, as it were. Well, you know, there's going to be comparatives which we have to meet, and it's going to drive it forward. Right? Keogh has showed that he got 80% improvements in efficiency and in reduction in deaths by simply collecting data. He didn't have to put any money into it. That's a fantastic model for government. So that's going to come in. I'm not so sure that the dental SHOs will stay in the units completely. I think there might be a drift. I'm not suggesting they're getting pulled out, but if you can see a lot of oral surgery being done outside the hospital, or some of it, you can see to get that work, you're going to have to go to it. So I suspect there'll be movements, but I don't think we can rely on running our service with them. I think there may have to be some accommodation there, and we may be losing much more of general core medical training. I think what is definitely going to come in is 24/7. And if 24/7 is coming in, that means that how are we going to provide that? Okay, so that means small units can't do that. So in London, for example, I can see centralization. I can see smaller units, Whips Cross, so-and-so, and around us, shutting down in the evenings and putting all the trauma into one center, and that the consultants, the larger body of them, so these units will then consist of 15, 16, 18 consultants, and that's how you'll get your on-call 24/7 cover. So there will still be the smaller hospitals, but you'll all be affiliated to a larger one. I think oncology and clefts will migrate out, and they sort of have anyway, and not necessarily oncology now, but clefts have. They're not in MaxVac units, they tend to be outside them. And certainly what's happening in London, where we are, we may have migrated out, and I suspect UCL and BAOMS might do the same in due course, i.e. they don't do trauma, they don't do so that's allocated to one of the trauma centers. I think that the universities, as Nigel said, are the big healthcare centres where all this money is being drilled in to improve things. I think that the consultants working there are going to slowly have to have higher degrees and work, because that's what the universities want in those places. And I see our subject being having trauma at the very center of it, as with lots of spin-offs. That will be the core bit. And I just hope that in this whole process that we can maintain our link with dentistry, and we have to actively do that. And I wish Colette actually said something earlier, is that if what she's saying is going to come true, she's managing referrals. There's no such thing as going to play golf with all your mates on the golf course and you get all their referrals any day. This is sort of gone, right? So that she is going to control the referral base, which means that all the oral surgery referrals are going to go basically down the way that the government wants them. I suggest the majority of them are going to go via an oral surgery route. And we will then be secondary referrers, i.e. they'll be saying, we've got a lump and a bump here, there, would you please see this patient, etc. And it is actually what happens to me now. So if we don't engage with this group, we are actually, I think, at risk of losing that referral pathway. So despite the fact that they need us to develop what they want, there's lots of benefit in it for us. So I've always supported this link with dentistry and with oral surgery, and I've supported it through the bad years, and I've been badly criticized for it. Actually, it's quite interesting how it's turning around, and there are a number of units in James Brown in Liverpool is running an oral surgery training program. In Birmingham, they're running one now. There are a number of people actually bidding for the oral surgery networks. One at just outside London. I don't know what's happening to London, or whether you're doing it, Simon Oakley's doing something. So what I'm trying to do is give you a flavor of where the process is moving, where commissioning is going, and I'm doing just the opposite to what Hutch is suggesting. I'm not actually suggesting we should be dropping oral surgery out of our name. I'm suggesting we should be working closely with them. It's part of our future, part of your future, part of where the work will come. It will be slightly different to today, though. But you have a chance of making it what you want, as opposed to someone else imposing it on you, which is likely to happen. That's what I'm scared of. So engagement. Lanko.
Me being the last person to talk, I think I'm going to summarize what's been said so far. Whether it's going to be any beneficial for the young colleagues, I hope it does. Let's see. I need some help. Part of my clinical practice, I work in Beijing, Peking Union Medical School. And as Nigel, I don't know the professor here, but as you said, the trainees come from general surgery, trainees come from orthopedics, they come from ENT, but they are head and neck surgeons. So whether in 10 years' time we are going to disappear as what Hutch said, oral and maxillofacial or maxillofacial facial surgeon, I don't know. But that's in 10 years' time. But what we are, I come from the district hospital based. There is a big opposition among colleagues to have a concept of centralization. I think that is the way it's going to be. When you guys become consultants, most of you are not going to be in London and Sheffield and Manchester. You're going to be outside. So you have to think of a concept of centralization. If not, we're going to be in trouble. So centralization in district hospital based, it is there, we should plan it, we should forcefully go for it. The benefits are, of course, it's been said, is improve the quality of care. The workforce numbers, we are short of trainees and we are short of numbers on calls and various things. And expenditure, the government is trying to reduce the expenditure. And the most important for us is we should be able to be in a position to subspecialize. And we should be in a position to innovate. Somebody asked earlier about vascular malformation. We should be in a position to be innovating vascular malformation in a district hospital base in South Coast or somewhere, or vascular malformation. So it's an opportunity is there when we centralize. Of course, there are things against, somebody to travel, and the individualized contact, as Mark said, golf course contact will be out. So we won't be having individualized contact for patients as well. The working pattern is going to change. Consultant-led service is there. You can't overrule that. 7-day week is going to come because it's politically extremely attractive. And it comes with that, again, Nigel said, it comes with the expenditure. Extra 2 consultants for each specialty in one area. Efficiency, I'm not sure. We need to change the culture on NHS, but when it comes, we need to improve the efficiency. Goodwill in NHS is extremely short supply. Whether it's going to remain when you guys become consultant in 5 years down the line, I'm not sure. The goodwill, you may have lost the goodwill. Again, I need to plea to Colette, and I'm sorry, Alistair already left. There's a problem of linking and keeping the dentistry and medicine and in maxillofacial surgery. If you don't have enough dental undergraduates coming into as an SHO trainee, if there is a restriction on the dental deanery, this guy should not come and take an arterial blood gas in the ward under supervision, then we will have a problem of not having dentistry and we become medical specialty. And that is a worrying sign. I don't want to, like Mark, I would like to see as a specialties keeping the dentistry and medicine together. And that is the only way we can promote the whole service. This is where my plea to Colette and the team of dentistry and dental deaneries, please think about this. Otherwise, in 10 years down the line, we will have problems. Commissioning, I think we've been pushed out everything in commissioning today. We know about the dental commissioning, we know about the problem in oral surgery in primary care, and the benefit and disadvantages to maxillofacial departments. And as one of the, I think Sandy showed a beautiful slide on Steve Thomas's paper on how the infection rates and abscesses are going up since the contract changes. So the infection and complications are going up. So it has a reflection on our undergraduate training and how we can interrelate. The best way, again, my urge is if we can have the interrelationship working, this type of things on the commissioning issues should be worthwhile. The next area of commissioning is the medical commission. We haven't talked about it. There are areas of skin cancers, areas of head and neck cancers, are medical commissioning areas, and that's going to affect you guys. When you guys become consultant, that commissioning part will be affected. So as an oral maxillofacial unit, I emphasize the term oral, staffing issues. Whether it's a dentally qualified SAS grades are remaining part of the maxillofacial unit. They should, in my opinion, I hope they do. Oral surgery should be part and parcel of maxillofacial practice. Trauma is our linchpin, trauma surgery. And trauma or composite trauma, not just soft tissue trauma or hard tissue, composite trauma. Dermatology, surgical dermatology is a major area. My practice, I do 1,000 skin cancers per year in my area, not all the areas. Surgical dermatology should be part and parcel of your practice. You need to find a way to push that. Head and neck cancer, yes, you know about that. Deformity surgery, we have some question marks. Salivary gland surgery and invasive and non-invasive surgery, and Mark is a prominent on the non-invasive component. Lump clinics, this is where you guys had to push yourself to be there. All the lumps on the head and neck, if you're not in the lump clinic, we will be losing a major part of our practice. You need to think about that in your practice. TMJ and oral medicines, don't ignore it. 20% of your outpatient clinic facial pain. Some are difficult patients, but don't say, I don't want to talk about it. If you say that, patients will go somewhere else. Don't ignore it. So as a maxillofacial unit, keep the staff together, keep the oral surgery with you, and keep the core things what we are doing now, which is exciting to us. At the same time, don't ignore TMJs and oral medicine and facial pain. Areas of instability. I worry about this. We talked about oral surgery and oral surgeons. There are only 20 oral surgery consultants, or 19 in the whole country. Alistair again gave us a big number. So there are issues. So there are instability. But working together, we can sort it out. Skin cancer and dermatology. Dermatology as a specialty, they are training surgical dermatologists. In my unit, when I started, hardly any surgical dermatologists. Now there are 5. So this is the one you need to think about. This is where the number comes. We just finished a nice guideline for lacerations. So we will be part of the important people who's going to present lacerations in charge. So same thing should happen for skin cancer. We're going to have a symposium in European conference next year on skin cancer surgery. It's the first time probably. I think we need to think on that because otherwise it's an area which we are troubled. Osteotomy, we have some problem. We are trying our ways. Ian's research and NENFOS, we are trying to find a way to overcome that problem. I hope when you guys become consultants, the simple osteotomy surgery maintains. The head and neck cancer, the fright is chemoradiotherapy. When I started 20 years ago, oropharyngeal cancer, we did resection reconstructions. And now last 5 years, that's gone down. It's going to even go down. So we're going to have reduction in the number of free flaps you're going to use. Hence the importance of centralization, working together as a team rather than isolated 3 flaps a year. It's not going to work. Facial pain, if you are not careful, you'll go to the primary care. Pain clinics are pushed out to primary care now. So if you don't keep the facial pain within yourself, you'll be losing it. Oral medicine, and you never know, there'll be oral medicine in regional centers where you consult on oral medicine. So it's a way to find a way to keep the areas of instability to us. This is, I hope, Mark and I, in our 2 years, we agreed we're going to try our best in our association, in the regions, in the unit, areas where we can try and focus and see whether we can develop things for your benefit as the years to come. Facial reanimation, units in facial reanimation. You need to think where you can go for a fellowship, where we can do this, and you can think about that. Vascular malformation, already we talked about it. Reconstruction of the ear, there aren't many centers, reconstruction of the ear, major issue. You need to think whether, do I want to be trained, 6-month course somewhere, trained in reconstruction. Robotic surgery is going to be a symposium in our conference. Robotic surgery is coming up in maxillofacial. Endoscopic surgery, decompression of the orbital apex. You need to learn, you need to find a flow. So every time you have a chance, please think of these areas. Thyroid and parathyroid, Professor Sandwich nicely said about the thyroid and parathyroid should be part and parcel of head and neck surgery. And that's the way it should be. But you need to be trained on endoscopic parathyroid, otherwise no point in fighting with the management, I'm going to do thyroid. So you need to know that. Snoring and sleep apnea is a major area. Aesthetics, I've been telling this in the last 8 years in our specialty, we need to push to learn aesthetics because it's a major volume for your practice. Craniofacial cleft and transplant on face. The first time the Glasgow group already got the license to do face transplant. They are maxillofacial team. They are the first one in the United Kingdom to get the license. So hopefully we'll have the first transplant in the United Kingdom in 2013. So areas that need expansion and crossing the boundaries, and think about it. This is where I very much like to see the younger generation to push yourself. So far this morning, none of my colleagues mentioned private practice. I think private practice is probably partly important 4-year family life, I think. And if can I ask this somebody, out of the trainees, what percentage would think of want to do private practice? Thank you. This is what's going to change your practice. The private practice concept is not going to be based in private hospitals entirely, and you're going to be go into chambers and open up your own clinics. The new consultant contract, there's a push that first 7 years you can't do private practice. So hopefully that type of restrictions doesn't come, because it will affect the quality of life to your family. If you depend on the NHS salaries, and when you have wasted or spent extra £150,000 on your course, that you have a duty to your family. So private practice is a thing you should not forget, that you should not think about it. And if you're going to do private practice, historically, yeah, if you're playing golf with your friend, you will have your wisdom teeth referral. That used to be the system. It's not going to happen to you. It won't happen. You can have some skin cancer, you can have some deformity, you can have some head and neck cancer of Middle East patient if you're working in London. It won't happen in Dorset, it won't happen in Hull or Sheffield. So you need to think, what can I do to improve my private practice? You need to think of aesthetics. And somebody said earlier, if you want to do a skill, you cannot do without training and accreditation and knowledge. And in order to do a practice in aesthetics, you need a mentorship. You need to think about it. If you don't have mentorship, you cannot go and do a private practice. You can't, patients won't come and spend £10,000 on you. So, 5 minutes, we said, we need to work together. We need to work with the oral surgery team, we need to work with the head and neck team, ENT team, we need to work together. We need to have everybody in the department rather than having 3 separate departments. You need to be enthusiastic to cross boundaries. Please think about that. I would very much like to see the crossing boundaries concept in maxillofacial surgery. Your freedom to practice will be curtailed by the little managers. So the individualism, the concept, the freedom you have will be controlled. In order to overcome, you need to be able to provide a comprehensive package of practice. You need the knowledge, you need the training, you need the expertise in areas you want to do. So in 10 years down the line, whether you want to do deformities, skin cancers, aesthetics, don't ignore oral surgery. Have a comprehensive practice. Thank you.
Thank you, everyone. That was really what the day was meant to do, was to give you a little bird's eye view into changes that were coming about, and to see if there was what we can develop out of council and get a feel for where things are going. Could I thank Colette, who started off today, and would you pass our regards on to Sue? Nigel, I hope you'd come with me now and to a restaurant around the corner and share some food with us. For all the rest of you, I hope that you found the day useful, and I would hope that maybe you could do a summary of it on your websites as you see it and what you thought of it, and get a feel for where we're going. And I hope it's been informative for the consultants as well, who have to lead on this in the interim. Thank you very much.